video, that would be great. Okay. Wait, hold on. Okay, thank you very much for inviting me, Dr. Park. And today's topic is congenitally missing lateral incisors. The substitute or not? That is the question. So the outline for today's presentation is introduction, incidence and prevalence, etiology, treatment options, which are canine substitution, tooth-supported restoration, and single tooth implant, and conclusion. So let's start with the introduction. So a patient comes to the office. She's a 17-year-old female with stating that her dentist told her that she has a few missing teeth. So upon clinical examination and on radiographical examination, on the X-ray, that she has retained primary teeth. So she has a retained primary upper left canine and the lower left second deciduous molar. And she has 4 congenitally missing permanent teeth: the maxillary lateral incisors, the maxillary third molar, and the mandibular left second premolar. So going through the literature, Shapiro in 1983 stated that tooth agenesis is the most common anomaly of dental development in men. What about the incidence and prevalence? In 1993, Simmons maxillary lateral incisors are missing in 2.2% of the general population. Then, in 2000, Bastardis stated that the incidence in the general population ranged 2 to 10% of the general population. And being the African Americans, a prevalence in African Americans of 7.7%. In Japanese, 9.2%. Severe agenesis, meaning 4 or more permanent teeth missing without taking into consideration the third molars, is in 0.25% of the general population. Being the third molars, the most frequently missing teeth, followed by maxillary laterals and the second premolars. And as always, females are more affected than males in a ratio of 3 to 2. What about the prevalence? A couple of years ago, I have a group of residents, and 3 out of 14 residents have congenitally missing lateral incisors. So in that particular group, the prevalence rose to 21%. So the difference between incidence and prevalence, incidence is in the general population and prevalence is in a specific group. Now, 3 residents were treated with 3 different treatment approaches. One was with canine substitution, the other one with a resin bonded bridge, which is a fixed partial denture, and the other one with single tooth implants. So what is the etiology missing teeth? Bastardis in 2000 mentioned that the etiology is multifactorial, but largely genetic. The MSX1 homo-box transcription factors are responsible for guiding the migration of the neural crest cells and guiding tooth development. Difference in their gene sequence can result in missing teeth. Lamour in 2005 stated that an affected individual with an autosomal dominant inheritance of agenesis with an incomplete penetrance and variable expressivity may have variable degrees of severity, meaning that instead of having one missing one missing lateral incisor instead of the two missing, or a peg-shaped lateral incisor instead of a missing one. And also, there in 2005, Lamour stated that there are some environmental factors, which could be jaw fractures, traumatic extraction of primary teeth, illnesses, drug irradiation, and nutrient deprivation. So what are the treatment options? So if you have a patient with congenitally missing lateral incisors, you have three options. The three options are canine substitution, tooth-supported restoration, or a single tooth implant. So how can we decide which treatment or which option should go? So Kokich Jr. and Kinzer in 2005 stated that in order to make the appropriate decision, we need to have an interdisciplinary consultation and treatment plan. We need to choose the least invasive and most conservative treatment option that will satisfy the patient's aesthetic and functional needs. Also, it should have the best cost-benefit ratio. And also, very important, we should fulfill the patient's expectations. So let's talk about canine substitution. Sacrison, Marco Rosa, and Torres Scott stated, and I agree 100% with them, that the major advantage of orthodontic space closure for young patients are the permanence of the finished result and the possibility to complete treatment in early adolescence without having to wait in order single tooth implant or condemn a young adolescent to a fixed partial denture. So what do we need to do and what do we need to evaluate in order to select a case or make sure that that case is suitable for a canine substitution? We have to take a look at the malocclusion, at the profile, at the shape and color of the canines, and the lip level. Regarding malocclusion, an ideal case for canine substitution should have a class 2 malocclusion with no mandibular crowding, or class 1 malocclusion with sufficient mandibular crowding or proclination that would benefit with extraction of two premolars in the mandibular arch. So we can say that in a class 1 with moderate and severe crowding, we can extract two premolars on the lower arch and do a canine substitution and use the canine as laterals. On a class 2 with no or mild mandibular crowding, we treat the lower arch non-extraction and we do canine substitution and finishing the case with a class 2 molar relation and using the first premolar as canine. Also, we have to take a look at the profile. So mildly convex or protrusive lips are a good indication for canine substitution, meaning that we can extract two teeth in the lower arch, retract and upright the lower incisors, and then with a class 1 molar and have canine substitution as we did on this case. What about the shape of the canine? There's a very variation on the shape of the canine. So in general, the canine is wider mesiodistally and buccolingually than the lateral incisor, as you can see on these two pictures. It has a thicker dentin, and for that reason, it has a yellowish shade. It has a convex labial surface that requires labial reduction and may need a labial veneer at the end of treatment in order to have a nice aesthetic result. The ideal lateral substitution the canine should have a similar color to the central incisor. It should have a narrow width at the CEJ, meaning the cemento. Should have a relatively flat labial surface and should have a narrow mid-crown buccolingual width. Why is that? In order to decrease the budget of the canine if we're going to use it as a lateral incisor. So in this case, this is an ideal case for canine substitution. Why? Because it has a narrow gingival margin, has the similar color to the central incisor. It has to have a narrow width at the CEJ, so you can take a look at the difference between these two canines. The side has a narrow width at the CEJ, in which if we do an enameloplasty to reduce the proximal surfaces and the cusp, it might be way easy to resemble a lateral incisor than the one on the left side that has a wide width at the CE. Also, if you take a look how convex is the labial surface of the canine in relation or in comparison to the lateral incisor, we might need to reduce that labial surface, make it a little bit more flat. It would be an ideal to have a narrow mid-crown buccolingual width. You can see on the left side, if we do not do enameloplasty, take a look at the buccal overjet that might be between the canine that will be used as lateral incisor, and then when we do an enameloplasty, that buccolingual overjet will be reduced. So those are the things that we need to take a look into consideration regarding the anatomy of the crown of the canine. So the order of the enameloplasty, as stated by Neil Kravitz, is the first thing that we need to do. We need to remove the cusp. Then we have to do an enameloplasty on the mesial and distal surfaces of the canine, which are often underperformed. Then we have to reduce the labial ridge, meaning we have to make a flatter surface on the canine. And many times we have to do a composite on the incisal angle to make it a more aesthetic, to have a more aesthetic results. And also we have to smooth the line angles. Also, we have to take into consideration the lip level. Why is that important? Because of the gingival margins, meaning the gingival sinus. On the left side, you can see how the central incisors, the gingival sinus of the central incisors are where they should be. And having a longer clinical crown, the gingival sinus are way higher. So what is the ideal? The ideal is as you see on the right side. So you have from centrals to canine, it has to go high, low, and high. So how do we treat these cases when we do canine substitution? We have to extrude the lateral incisor, the canines. Then we have to reduce the incisal border. And in this case, we reduce the incisal border and we did some composite on the mesial-incisal angle to have a more aesthetic result. Another problem that we have is root prominence. So if you take a look at the lateral incisor and at the canine, you can see that the canine has a wider root buccolingually. Another problem that we have is if we use the brackets of the lateral incisor, it has a torque prescription between 3 to 10 degrees positive. It all depends on the prescription of the bracket prescription that you are going to use. And the canine has a 0-degree torque with a range of -6 to +6 degrees. So if we use the canine bracket on the canine, and we're going to do canine substitution, we have to place lingual root torque on the canine to compensate for that. So what can we do if we don't want to bend or place individual torque? So we can use and substitute the bracket that we're going to use. So we can use a maxillary lateral incisor bracket or a maxillary central incisor bracket. The difference is going to be on the mesiobuccal, on the mesiodistal tip, and on the torque prescription. The maxillary lateral incisor, if you're using an MBT prescription, has a plus 10 degrees of torque, and a rod prescription has plus 8. If you're using a central incisor bracket, it has a plus 17 if you're using an MBT, or a plus 12 if you're using a rod prescription. So Kravitz suggested the reason for using a central incisor bracket is to add palatal root torque that will counteract the canine's root prominence. So why it's important to use a different bracket? So if you're using a central incisor bracket, you are going to have a prescription of about 12 to 17 degrees, depending on the prescription. So in 1967, George Andreessen, who is the one who introduced the wire into orthodontics, made a mathematical study between the bracket slot and the wire size. And mathematically, he measured the amount of play that the wire has on the bracket. So on his mathematical study, if you're using an 18 by 25 bracket and you're using a 17 by 22 wire, that wire plays 2.7 degrees. I know that most of the time, if you're using an 18 by 25 slot, most of the practitioners use a 16 by 22 a 16 wire to finish. Mathematically, that wire plays 5.5 degrees, meaning that from the prescription that the bracket has, you are losing 5.5 degrees. If you're using a 22 by 28 slot and you're using a 21 by 25, you're losing 2.4 degrees. And if you're using a 21 by 28, you're using 2.1 degrees. So let me remind you that this is a mathematical study, but that brackets are oversized and wires are undersized. So in 2017, Kravitz stated that for 0.001 of vertical play or slope between the slot and the arch wire, approximately 5 degrees of torque is lost, meaning that there's a 1 to 5 rule of thumb. What does it mean? That it means for every thousandths of an inch of between the wire and the slot, you are going to lose 5 degrees of torque. That's why it's very important to use the bracket, which can provide you the highest amount of torque. Some practitioners, instead of using a central incisor bracket, they use a lower second bracket, which increases the amount of torque. So that's another bracket that you can use. So in this case, I did use the maxillary central incisor bracket. As you can see, the cane central incisor have the maxillary central incisor bracket. Okay, let us analyze a case. So we have a patient that comes to the office. She's 14 years of age. We can see that she has her facially, she's within the normal limits. Upon smiling, she doesn't have any gingival display. We see that she has a huge diastema between the central incisors, a kind of consonant smile, and she has an overall straight profile with a straight lower third. Occlusally, she has a bilateral class 1-ish relationship, probably an end-to-end class 1 relationship on the molars. She has a quarter of class 2 relationship on the premolars. The left canine is in class 2, the right canine is end-to-end. She has a huge diastema, limited overbite, limited overjet. On the upper arch, she has missing lateral incisors. The maxillary first molars are mesially rotated. On the lower arch, looks really nice, no big problem. Then, upon the regular radiographic examination, we can see that there's no pathology. She has the third molars developing, and she has missing maxillary lateral incisors. Then, on the cephalometric X-ray, she has a class 1 skeletal relationship with an A and B of 0. She has a -1 of width. She's normodivergent, 26 of FMA, 31 to mandibular plane to SN, maxillary incisors and mandibular incisors, normal limits. So we all know, and we do teach here in the US, that we need to treat and we need to practice evidence-based dentistry, which is an approach to oral healthcare that requires the judicious integration of systematic assessments of clinically relevant scientific evidence relating to the patient's oral and medical condition and history, with the dentist's clinical expertise and the patient's treatment needs and preference. So what does it mean doing evidence-based dentistry? We have to use our best research evidence. We have to use our clinical expertise. We need to see the patient's needs and the patient's requirements and expectations and combine them in order to do an evidence. So let's take a look if this case complies with the substitution requirements. So let me remind you that the requirements have to deal with malocclusion, profile, canine shape and color, and lip level. So let's take a look at the malocclusion. So she has almost a class 1 relationship with spacing on the upper arch, some space distal to the canines, limited overbite, limited overjet. She has maxillary first molar rotated. So if we derotated, we might be able to achieve a class 1. We can bring those premolars back into a good class 1 occlusion. We can close the diastema and bring the canines into a class 1 occlusion. She has a good lower arch with no crowding at all. So I would say that with malocclusion doesn't comply with the requirements. What about profile? She has a straight overall profile with a straight lower third. So she has no convex profile and she has no protrusive legs, meaning that her profile doesn't comply with the requirements. What about the canine shape and color? The canines are wider than the central incisor, and they are yellower than the central incisors. So they comply with the substitution requirement. And what about the lip level? The lip level, she has a low smile line. She doesn't have any gingival display upon smile. So on the lip level, she complies with the canine requirements. So what would you do? And I would like to ask the panel, Dr. Charlantini and Dr. Hirschaut, if they could join and give a comment of what they would do on this case. I'm going to stop sharing so we can have that discussion.
Okay, so if I might start. I think in this case, I would open space for the lateral, and I will tell you why. There are two reasons that I'm thinking. First, the upper arch is a bit deficient. The AMB is 0, the maxilla is a little bit retruded at 80, and she has a flat profile. And we know from the studies of Behrens and others that the nose and the chin are gonna keep growing. So I don't wanna take out, I don't wanna treat her like a substitution case in this situation. I would open space for the laterals. Even though committing to a lifelong problem that is having replacement for the laterals. And you mentioned a very interesting article by De Rosa, and there was a counterpoint in the AJO and the JCO between De Rosa and the Seattle group, and the Seattle group was taking the position in favor of opening the space, and the Rosa with the person were taking the position of closing the space. So I am aware of the problems that present long term having an implant or a Maryland bridge or something for this young lady. But in my opinion, in this case, for facial concerns and for maxillary tooth structure, I would open space for a lateral.
Perfect. Thank you. Dr. Ciarlontini?
Yes, I agree with Miguel, because the main concern is the profile. And if we try to mesialize the upper lateral segments, you cannot improve the profile of these patients. And maybe you have a good occlusion, class 1, so if you treat it, you don't get a nice occlusion as actual. Maybe you can do something harmful to the patient. Yes, maybe Rosa, in these cases, they prefer to open in the first premolar areas to close the space. But if you don't want to close the spaces, instead of opening in the lateral, they open on the first premolar, where you have less problems with implants. It could be another option. It depends also on the aesthetics of the canine. The canine has very little in these cases. They can, you can evaluate also the canine substitution, because they are very little, they are very nice, but the color may be a problem. I think that the best thing is to have the lateral, but not with the implant. Maybe also, I see also in France, they use a lot this cantilever bridge, also disilicate cantilever bridge, and the aesthetics is very, very good. Very, very good, without metal. And also the prognosis over the years is very good.
You know, I also have used opening space, and I don't want the patient to be committed to lifelong, because she's gonna finish young. I don't know what age she is, probably 14, 15, so she's gonna have to wait until early 20s for the implant. So you just might put a mini screw and put like the temporary on the mini screw, and that way also you're maintaining the bone, because the mini screw is acting as a stimulus, and you might just do a little oval pontic, and it will contribute to the gingival architecture on the area.
Yeah.
So I think that's what I would do in this case.
Yes, it's a good idea. If you go for implants, it's a good idea.
Perfect. Anything else to add? I want to continue. Anything else, Roberto or Miguel?
No. Okay.
Perfect. Thank you. So let me continue sharing the screen. Okay. So what would you do? So I have three possible options. The first option is non-extraction, canine substitution, and finish class 2 molars. The second one is non-extraction, achieve class 1 posterior segment, close diastema between the central incisor, achieve class 1 canine, tooth-supported prosthetic restoration of the incisor. Or the third option is non-extraction, achieve class 1 posterior segment, close diastema between the central incisors, achieve class 1 canine, single tooth implants on lateral incisor position. So what are the latest trends? So a couple of months ago, Naum published this paper. And they stated that a trend away from space opening and prosthetic replacement toward orthodontic space closure was observed from 2000 to 2017-2018. This may reflect a change in attitude toward prosthetic replacement and great optimism with biomechanical strategies with the implementation of temporary anchorage devices. So, as both of you, Miguel and Roberto, mentioned patient's age and so on, I decided to treat this case with canine substitution. And in this case, we used a lateral incisor bracket on the canine, as you can see here. Okay, so we started leveling the arch, both arches, leveling the arches, closing the diastema between the central incisors, then closing, bringing the canines into the lateral position, and then bring the whole maxillary arch. How am I holding the anterior segment in position? I'm using a TAT-supported T-bar. So I have two TATs, two temporary anchorage devices, holding the central incisors. So one of the big problems using a lateral incisor bracket on the canine, besides the cuspid, it's the buccolingual. So remember that the lateral has an inset. So I'm having problems with the buccolingual position of the lateral incisor. So I had to do some bends at the end of treatment. So by using a TAT, I'm holding the anterior segment in place. I'm finishing the case. I'm doing some compensating bends on the first premolar to bring it down, on the lateral incisors. And this is the case at the end of treatment, about 2 years later. Facially, she matured quite a bit. These pictures were taken just at the debonding appointment, so there's some gingival hyperplasia. She's happy because we didn't have to wait or replace a fixed partial denture, or she has a nice profile. She has a class 2 molar relationship bilateral. I'm using the first premolar as canines, and we did some enameloplasty and recontouring on the canines in order to resemble the laterals. Are they really nice? No, they are not. They are really nice. Could I have done a much better job with the shape of the canines into convert them into the laterals? Yes, but the patient didn't want it. She wanted that. She wanted it that way, and parents wanted to finish this way. So she's happy, and I'm happy. So here are the views. Here's the panoramic X-ray. Here is the lateral X-ray with the measurements, and here is the superimposition. So in the superimposition, we can see that we did change the position of the lips. So the lips went down and back a little bit. The mandible went down and back a little bit, so it opened a little bit, and the chin went down and back. So what happened on the maxillary superimposition? So the central incisors were labially placed, and we increased the torque, and there was a mesialization of the molar. We did finish with some class 3 case, so we can see that there was some mesialization and extrusion of the molar. And on the mandibular superimposition, we can see that there was a slight lingualization and extrusion of the incisor, and there was a change in the occlusal plane. So why did the mandibular plane open? It opened because the extrusion of this and the side effect of the class 3 elastic, there was not an anterior open bite because of the extrusion of the lower incisor. So it was a fairly decent result. So what other options do we have when we have congenitally missing lateral? So we have a tooth-supported restorations that can be a resin-bonded fixed partial denture, as Dr. Charlantine mentioned, a cantilevered fixed partial denture, and a conventional full coverage fixed partial denture. So these are resin-bonded FPD, the one that the resident had. She allowed me to use this picture on the presentation. Or, as Dr. Charlantine mentioned, a cantilevered FPD, in which there's a very limited prep on the canine, and it's a casted, a cantilevered pontic with a very nice aesthetic result. Or a conventional full coverage FPD. So what is our role as orthodontists when we have this kind of issues? Our role is to space management for prosthetic restoration. So how much space do we need? Lombardi stated that when viewed from the direct anterior, the central lateral canine should have a ratio of 1.6, 1, and 0.6, following the golden proportion. So if the lateral is 1, the central should be 1.6, and the canine should be 0.6. Kokich stated that for best aesthetics, the width of the lateral should be approximately 2/3 the width of the central incisor. So if the central incisor is 3/3, meaning 1, the lateral should be 2/3 of the central incisor. What happens when we have a missing lateral incisor on one side and a peg lateral on the other side? So what I used to do, or what I always do, is do a diagnostic setup. This is a very old diagnostic that I did in the mid-80s, in which the patient had a missing lateral incisor and a peg-shaped lateral incisor. So I did a diagnostic setup, placed the proper occlusion, and then I was able to realize how much I needed to construct or build up the lateral incisor and leave a good amount of space for the prosthetic on this case. The third option is a single tooth implant. So what are the advantages of single tooth implants? They have a high success rate and longevity. Leave the adjacent tooth untouched. However, it requires surgical intervention and cannot be placed until facial growth spurt is complete. So there's an important issue on the timing of implant placement. So rapid facial growth is between the ages of 12 and 15, and vertical growth is the last to reach completion around age 20. So what happens with implants? Implants cannot erupt as teeth, so placement prior to completion of growth results in infraocclusion. So this is what happens. So this is a patient in which they placed 2 implants on the central and lateral before finishing the vertical growth, and a few years later, you can see that infraocclusion because they do not erupt as teeth. So to determine cessation of growth, serial cephalometric radiographs 6 months to 1 year apart should be traced, and superposition should be done in order to show the vertical change. So this is an example of an extreme grower. Okay, so you can evaluating the two different time frames on the X-ray. We can evaluate if the patient is growing or not. So Marco Rosa, Gemilian, and Leticia Perillo did a study on orthodontic space closure versus, and they stated that orthodontic space closure and implant of missing maxillary incisors produced similar, well-accepted results. None of the treatment impaired temporomandibular joints. So both groups didn't have any problems with TMJ function. However, infraocclusion was evident in the implant patient. So all on the patients where they placed the implants, infraocclusion was evident. And space closure patients also showed better periodontal health in comparison to patients. So yes, they're successful, but there are some issues with implants. 2 weeks ago, I attended the South African Society of Orthodontic meeting, in which Björn Ludwig was the presenter, and he presented papers in which they showed that even on adult patients, there's some vertical change and there's some infraocclusion after some period of time. So even patients that we think and we believe that they are done growing, they presented some infraocclusion. So we have to take that consideration when placing implants. So what about implant site development? So we can extract the primary lateral and allow the canine to erupt adjacent to the center. Then distalize the canine into its appropriate position. And we have to be aware that the buccolingual width in the lateral area is stable, meaning there is less than 10% of reduction over a period of 4 years. However, 34% reduction over if the space is edentulous. So we have a time frame that in which we can create the implant site and place the implant. So we allow the canine to erupt adjacent to the central incisor. We can distalize the canine into the appropriate position. And then we need some space requirements. So we need 1 millimeter of palatal bone, and we need 2 millimeters of buccal bone. Why 2 millimeters of buccal bone? Very important, because if we don't have those 2 millimeters, there's the color of the gingiva on the implant is going to change from pink into a bluish. It looks really, really bad. And we need 6 millimeters mesiodistally, 6 millimeters for the crown, meaning 6 millimeters mesiodistally between the roots. Why? Because we need 3 millimeters of diameter for the implant, and we need 1.5 millimeter between the implant and the adjacent tooth. So we need 1 millimeter of palatal bone, and 2 millimeters of palatal bone, and at least 2 millimeters of buccal bone. And we need 6 millimeters between the adjacent teeth, meaning 3 millimeters for the implant and 1.5 millimeters between the implant and the adjacent teeth. What about the interradicular space? Incisor proclination results in an inadequate space between the roots, having the wagon wheel effect. Normal inclination provides adequate space between the roots. For example, we have the 6 anteriors, and we're leaving a space for the lateral crown. So this is enough space for the lateral crown. But if the incisors are proclined, there's not enough space for the implant, as was stated by Larry Andrews in the 6 keys of occlusion when he talked about the angulation of the teeth. If we have a normal incisor position, having the same amount of space for the crown, we have enough space for the implant. What about the interarch space? So the deep overbite must be corrected to accommodate at least 5 millimeters of interarch space for the restoration. Once the space is deemed appropriate, it is best to hold the incisors with a fixed retainer. So we have a temporary space maintainer with a fixed retainer. So the space could be maintained by a removable retainer with a prosthetic tooth, by a resin-bonded fixed partial denture, or by a temporary crown supported by a mini implant, just as Dr. Hirschaut commented. So here I have a removable retainer with prosthetic tooth. So here are the 2 prosthetic teeth on the removable retainer, the resin-bonded fixed partial, or a temporary crown supported with a mini implant. So this mini implant is placed on the alveolar ridge, and it is supported, and it supports a temporary crown. What is the issue? The idea of placing an implant on, it's a good one. And the issue when you're placing this kind of mini implants on the alveolar ridge, since the mini implant is very, very narrow, it's 1.8 millimeters in diameter, or 1.7, they have a higher tendency to break. So I have placed 3 of them. Thank God none of them have broke. But what Björn Ludwig stated, he stated that most of his pontic supportive tats like this one got broken. And in order to remove tats, well, the purpose of the tat on the alveolar process is to keep the bone and to prevent bone loss. So if it's broken and you have to remove it and then place an implant, you are going to destroy the bone. So you should avoid placing. So what does the literature says? So Wirten, Melsen, Fuja, Chen, and Dahlstrom placed an horizontal tat that prevented the alveolar atrophy of an extraction space, even if unloaded. So I want to thank Dr. Ciarlantini for allowing me to use slides. So Wirten Melsen placed a tat perpendicular to the alveolar bone in dogs, and they showed that the bone didn't atrophy. They maintained the bone, the amount of bone. So Dr. Ciarlantini and Wirten Melsen did a study that was published in 2017. They did a 5-year follow-up of 5 patients with a genesis of the maxillary lateral incisors. They used 6 mini implants supported temporary pontics after orthodontic space opening. And they had a 5-year follow-up checked every patient every 6 months. So this is courtesy of Dr. Ciarlantini. So he placed bicortical tats perpendicular to the alveolar bone, and he placed indirect pontics with an indirect anchorage to hold pontics. This is the initial. So he showed vertical cuts with indirect anchorage on the pontics. This is 2 years later. This is 3 years later. And this is 5 years later. So what's really, really amazing is that I'm going to go back and look at the position of the incisors of the pontics in relation to the central incisors, and on the initial 2 years, 3 years, and 5 years. There was no infraocclusion on all the cases. And take a look at the gingival architecture. It's really, really amazing. And they showed that there was no inflammation around the pontic over a period of 5 years. There was inflammation around the meniscus on one patient at the 2-year mark and at the 3-year mark. There was obstruction around the meniscus. There was a ligature breakage on one patient on the 2nd year and on the 3rd year. There was gingival impingement on 2 meniscus at 5 years. And there was discoloration of the pontic at 3 years and 1 year. So he showed in scans that the alveolar process remained. There was no atrophy of the alveolar process, and even increased in some instances. So they concluded that the bicortical placed stats were able to preserve or even increase bone density and morphology of the alveolar process, whereas the maintenance of distance between the pontic and the alveolar mucosa allowed for continuous vertical development. So after reading this paper, this is the technique that I'm using. Liano Ciarlantini and Bertie Melsen stated that this method allows for normal development of the alveolar process, both in height and width. It is limited to a specific age and can possibly be used as a temporary solution during a prosthetic reconstruction phase. So let's take a look at one more case. So we have this patient, African American, nice, no problems on the face, nice smile line, big diastema, central incisors, a good position for a good lip position, slightly convex. However, for African Americans, this is within the normal limits. She has a class 1 bilateral occlusion, big diastema between the central incisors, midline, the left central incisor shifted to the left, very limited crowding on the lower arch. Here's a panoramic X-ray, and on this one I used the WEBCEPH X for the analysis. So she has a class 1 skeletal. She is normodivergent, and she has like upper and lower incisors. And what would you do? So I'm gonna stop sharing, and I would like to ask the panel what they would do on this instance. So, Dr. Ciarlantini, if you would like to comment.
The last case was borderline. You can close, you can open. But this case, I think, with this very, very large tongue, to close the space is very dangerous. Sometimes you can have an reopening of the space. So I think that I can, in this case, I would distalize the 1-3 and mesialize the 2-1. and I will insert 2 cantilever pontics here. Or
okay, perfect. Dr. Hirschhout.
Well, I was looking at the face, and my concern here is the opposite. Even though she's African American, I think she has a deep curved P. Didn't mention the curved P, but I'm sure if you measure it, at least you need there another 2.5 to 3 millimeters. So actually, in this case, I'm gonna go the other way. I might think of extracting lower premolars and doing like a substitution case. I have to disagree with Roberto this time, because I think you do have mild crowding, but you do have some curvous P, and even though she's African American, her E line, if you look at the lip, it's way forward. It's gonna go more forward once you level it, and I think I would do lower premolar extraction in this case.
Okay, perfect. So we have a lower premolars and canine substitution, and then we have opening space for either an implant or an FPD. Perfect. Let me go back. And what would you do? So I have 3 options. The first one is non-extraction, maintain class 1 posterior occlusion, achieve class 1 canines, open space for a single tooth implants on maxillary lateral space. The second option is maintain class 1 posterior occlusion, achieve class 1 canines, open space for tooth supported restoration on maxillary lateral space. Or non-extraction on the maxillary arch, extract mandibular first premolars, retract and upright maxillary and mandibular anterior teeth, and canine substitution. So let's see if the case complies with the substitution requirements. So let me remind you that we look at malocclusion, profile, canine shape and color, and lip level. So according to malocclusion, she has a class 1 proclined lower incisors, very mild crowding, very limited overbite, tendency for an anterior open bite. According to the requirements, she complies with the malocclusion requirement. What about the profile? She has a convex lower third protrusive lips. And remember, she has limited overbite, limited overjet, so she complies with the profile requirements. What about the canine shape and color? Let me go back on this one, because I did not please. Take a look at the mesiodistal width at the CEJ. So it's narrow. So go back at the shade. So it matches the central incisor width and convexity, and it's not as yellowish. So yes, it complies with canine shape and color. What about lip level? Low smile line. Yes, she complies with a low smile line. So she complies with the 4 requirements. So that's exactly what we decided to do. So we extracted the lower first premolars. We did reciprocal closure, and we used, on her case, we used a central incisor bracket. On the case, central incisor bracket, and this is a central incisor bracket. So this is clean cut orthodontics. We are consolidating the anterior segments, then we are sliding mechanics to retract both anterior, upper and lower anterior teeth, and this is the case after we did the enameloplasty and finishing the case. So it looks really, really nice. we send the patient for the extraction of the third molar, and this is the final result. So this is the web, and this is the comparison between initial and final. And this is the WEBCEPH overall superimposition, in which we can see the amount of retraction of the incisor and the change. There was no big change on the profile. So what is the impact of oral health quality of life and self-esteem on patients with missing lateral incisors after orthodontic space closure? So they did a single-blind randomized controlled trial. So they concluded that the spacing resulting from missing lateral incisors had a negative impact on the oral health quality of life and self-esteem of the patients, while orthodontically closing those spaces had a positive impact on those aspects. So you can see, even though in the beginning she had an amazing personality and she was really happy, take a look on her smile at the end of treatment. Her personality improved in such a way that she was really, really happy. And take a look at, there was a slight decrease in the lip recumbency. However, it is still within the range of normal for her ethnicity. Conclusion. You have to choose the least invasive and most effective treatment option that will satisfy the patient's aesthetic and functional needs. Communication between both specialties is crucial for treatment success. I want to thank Dr. Park, WEBCEPH X community, Dr. Miguel Hirschau and Dr. Roberto Charlantini for being on the panel today. And I really, really appreciate you taking your time. And if you have any questions, I'll be more than happy to answer. Thank you very much.
Okay. Thank you so much, Dr. Abraham. I really appreciate your efforts. Since we have special panels for today, 2 panels, we will have time for the discussion about panel and speaker. First, about the webinar. Meanwhile, I will collect some questions from the chat box and post them on the screen. Then Dr. Abraham will answer them together with the feedbacks of our panels. Okay, panels, Dr. Robert and Dr. Miguel and Abraham. Panels, do you guys have comments or question in regard to today's webinar?
I do have a comment on the first case that Abraham showed, and Abraham is my good friend. I like him very much, but I think
that's fine. I have a thick skin.
If you would look at this girl long term on the first one,